Here. Thank you for having me. I want to apologize. I've been really ill. This is the most I'm going to try and talk in about the last 3 weeks, so bear with me. Towards the end, my voice may start to go. If I start to sweat and get jittery, it's Dr. Eichenhorn's fault, because it's got me so hopped up on steroids and bronchodilators, it's not even funny. So I beg your indulgence. I'd like to thank you guys for having me today to talk about pancreatitis. I'm really going to focus on, pancreatitis is a spectrum of disease, obviously, and what I want to focus on today is primarily necrotizing pancreatitis, which is kind of an extension of acute pancreatitis, but I think it's probably the area where we want to focus on the most. So that's what I'm going to do, and then focus on infected versus non-infected acute necrotizing pancreatitis. This is a talk that some of you, I think, probably may have heard, particularly those who may have rotated in the SICU. And one day when we didn't have anything to talk about, I pulled a talk out of a can and gave it. So you may have already heard it. And for that, I apologize. But hopefully for the rest of you, it's something interesting. I've got nothing to disclose. I think we're just going to talk about some stuff. And I'd like to do this based on the literature. There's some pretty good consensus standards out there on what to do in a lot of these issues. Some of them are a little bit controversial, and some of them are maybe not quite widely appreciated or recognized. I'm more than happy to make this a discussion format if you guys want to, so feel free to raise your hands or shout out disagreements or agreements or whatever, and we can talk about some of this stuff certainly as we go through it. The basis for most of the guidelines and standards that I'm going to talk about comes from this article. It was published in 2013. A bunch of different pancreas groups, the International Association for Pancreatology and the American Pancreatic Association put out these guidelines for the management of acute pancreatitis. I would recommend this to you to put in your file of those landmark papers of what things you want to have at your disposal to refer to that gives you a level of evidence and standard recommendations and things like that. So almost all the stuff that we're going to go through today, the questions we're going to ask ourselves and hopefully answer, are going to be based on the information that came out of this work. So just briefly, some definitions so we're all on the same page. This can sometimes get a little bit of confusing. You can find different definitions for everything, but this is basically what we're going to be talking about. Severe pancreatitis versus necrotizing pancreatitis. Certainly there's all kinds of definitions and grading scales that you can look at for severe pancreatitis, but most of the criteria are based either on clinical, laboratory, and or imaging criteria. Severe pancreatitis, as I think everybody in the room knows, mimics sepsis and certainly generally has a component of multi-organ failure associated with it, and that's what makes it sometimes difficult to differentiate from different disease states, and makes the proper management sometimes hard, because you've got to, what is the problem here? Is it an infectious source? Is it a non-infectious source? Is this just an inflammatory state or an infection-driven state? And that sometimes makes it really hard to deal with. A relatively small percentage of these cases involve frank necrosis, but those that do certainly have much higher morbidity and mortality, so we want to make sure that we identify those. And the definition of necrotizing pancreatitis is predicated on the fact that we have some guide of perfusion of the inflamed pancreas, and that generally involves some contrast-enhanced radiographic study, either a CT or an MRI, and both those carry some specific risk to them, so it's not always easy to do in this patient population. Talked about that. Something that always comes up, and we're going to kind of step through this in a little bit of a temporal fashion, how you'd approach a patient and the questions that come up as you're trying to work from diagnosis to management. So one of the things that always comes up is, okay, do I have to image everybody with pancreatitis? And I think clearly the answer is no. And in the vast majority of cases, especially in those cases where the diagnosis is fairly certain and unquestioned, then certainly sometimes early imaging can actually be detrimental to the patient, because they're still in that inflammatory phase. They're frequently under-resuscitated. And imaging, especially contrast-enhanced imaging, can sometimes be really hazardous for these patients. And more often than not, it really doesn't provide you with any additional information that's going to change your management. So in fact, I would recommend against contrast-enhanced imaging in the early phase, unless there is some diagnostic uncertainty. You're trying to differentiate between maybe a perforated viscous or an intra-abdominal catastrophe versus pancreatitis or something else. And sometimes that is difficult. The failure to respond to conservative therapy, this is something that you would image these patients later on. So, it's not very frequent that we see patients acutely, say, in the emergency department that come in and they've been sick for 3 weeks. That's not the way it works. Now, sometimes we get these patients in transfer from other places that have been smoldering somewhere else, and then the CT scan maybe become more helpful and help us really differentiate people that may or may not need something done. But in the early acute phases of this disease, imaging is not necessarily warranted. Again, I want to make sure that we understand the difference. Back in the past, we used to take patients and from a surgical standpoint and say that if they've got necrotizing pancreatitis, they need an operation. A lot of that stuff has been debunked. Patients don't do very well, especially when they're operated on early. But we want to see if we can differentiate between patients with either non-infected or infected pancreatitis. This is a study that came out of Europe, the Netherlands, and the Italians do a lot of pancreatic research, and some of their data is really good. They've got nice database registries, especially the Dutch folks, and a lot of the literature that's come out on pancreatitis comes from those groups, and it's really pretty good data. Here's patients with organ failure just to show you the severity of the disease. And I've entitled this slide, Necrosis is Bad, but Infected Necrosis is Worse. So you can see here, we'll take patients with edematous pancreatitis, that's the EP on the left. Pretty significant morbidity and mortality goes along with that. But once it gets to be necrotizing, in other words, we do an enhanced study and part of the pancreas doesn't light up, there's a significant increase in the morbidity and mortality of those patients. And then if that goes ahead and we look at those 86 patients that fell into that necrotizing pancreatitis group and we just looked at whether they were sterile, that's the SPN group, versus infected, the IPN group, you can see that morbidity, organ failure, et cetera, is significantly increased in that patient population. So patients with infected necrosis is worse than edematous, and infected necrosis is worse than regular old necrosis. And here's just some more data from that study looking at mortality. You can see down on the bottom, mortality is about 8-fold in the infected group versus the non-infected group. So that kind of tells us that what we're really worried about here is this necrosis infected or not? That's really the differentiator that's going to change our management. The patients that just have either edematous or necrotic pancreatitis that's not infected, those patients are treated basically the same. We'll talk a little bit about what that treatment is in just a minute. But the real differentiator here, is there infection present or not? That's the question that we have to ask ourselves really as clinicians. So again, the management is based on infection versus not. If it's sterile, whether it's necrotic or just edematous and not necrotic, it really doesn't make a difference. The management is supportive in nature. We'll talk about what that is, and it's expected in nature. Very few of these cases you'll see them acutely present infected. That's just not the natural history of the disease. The infection generally takes at least 2 to 4 weeks to set in. So any patient that you see acutely, the likelihood of them really having infected pancreatitis or infected necrosis, really that would fly in the face of the usual presentation. So in that respect, you really don't have to worry about it that much. And just another reason why not to subject the patient to contrast-enhanced imaging early on, because it's really probably not going to help you in your diagnostic workup. With infected necrosis, though, the patients almost always need some intervention. That intervention has changed over the last 10 or 15 years, and the management of infected necrosis is really starting to evolve. And what I'll talk about later in this talk is where we go nowadays when we are presented with infected necrosis. And the aim certainly is at source control of that ongoing problem. just a little bit about kind of the overview of the management of sterile necrosis. Some of these questions are a little bit controversial, but these are the things we want to touch on. Fluid therapy, I think everybody in the room is familiar with this. Fluid therapy for pancreatitis is pretty darn aggressive. And some papers, get really, really aggressive. The problem I think that we get into sometimes is we've got to know how to monitor these patients and know when to turn it off. It's good to be aggressive, but you have to monitor and pick your endpoint and then stick with it and make sure that you don't overly resuscitate some of these patients, because some of the problems that they can get into down the line are a direct result from that over-resuscitation. Things like abdominal compartment syndrome, respiratory failure, and things like that they can get into that we want to be careful about. But certainly, we don't want to under-resuscitate them, and there's a lot of good literature out there that fluid therapy should be the mainstay. So we've got to be cognizant of our goals of resuscitation and make sure that our patients are meeting them when they were trying to resuscitate them with pancreatitis. Nutrition's another big thing. This is one of those areas that has somewhat been a little questionable maybe, or controversial. A lot of old wives' tales about whether you can or cannot feed pancreatitis, whether you can feed them pre-pylorically or it has to be post-pyloric, et cetera, et cetera. The bottom line is patients do much better if they have enteral nutrition. And so we need to use their gut if at all possible. It really does not matter whether we feed them pre-pylorically or post-pylorically if they can tolerate it. Some patients will have a significant gastric ileus or gastroparesis, or some of these patients even have a relative component of gastric outlet obstruction. So obviously if they have that, you can't feed them pre-pylorically. But if not, use their gut if at all possible, and if you can use their stomach, it's just as easy to use it. That's kind of the take-home from all this. Any questions about that? Because again, there's sometimes a lot of controversy. Yeah, Bruno.
Is there a way we can make sure that is a universal request from our consultants? Because I always feel like we're playing chart wars about feeding patients with pancreatitis every time we have one on the medical side.
Really?
Yes.
Well, part of my goal, I guess, today is to get us all on the same page. And these are fairly, again, these are evidence-based guidelines that I'm not going to quote all the literature to you, but if you go to this paper, they've got the levels of quality of the evidence and everything else that you can refer to, and long reference lists and everything else that you can go to. I'm just kind of synopsizing it here for everybody, and it's certainly, I think, our goal, whether you're in the medical critical care unit or surgical critical care unit or anywhere else, that we provide our patients with some standard level of care that's appropriate based on the evidence. And,
I'm surprised I still see it, but I still...
enteral nutrition is good. Use it when you can. ERCP, this is something that also comes up sometimes. And the take-home from all this is if they've got cholangitis, do it. If they don't have cholangitis, don't, basically. Making that determination about whether they have cholangitis or not can sometimes be difficult. Okay, but certainly if they have evidence of choledochal lithiasis or biliary ductal obstruction, then yes, ERCP can be helpful. If they have the triad of hyperbilirubinemia, right upper quadrant pain, and leukocytosis, and that gives them a clinical scenario consistent with cholangitis, then yeah, most of the time they will need ERCP. Whether they need emergent ERCP or relative elective ERCP really depends on the clinical status of the patient. In our unit, at least, we see a lot of elderly folks that come in with acute cholangitis, and that's a deadly disease, and sometimes we have to twist the arms of our GI colleagues, especially on the weekends, to come in and do it, but certainly emergent ERCP in those scenarios is certainly indicated. The problem is it's not in a lot of other cases. So just the fact that you've got a supposed etiology of biliary pancreatitis in a patient with severe pancreatitis, ERCP is not necessarily indicated in those cases unless there is concern that there's overlying cholangitis that may be making the patient worse in addition to that. Any questions on that? I think that's something that comes up, and I think our GI colleagues get called a lot for ERCPs in some of these patients where it may or may not be indicated. Antibiotics, probably the most controversial question, although I think it's gotten a little clearer in the last 2 or 3 years. 5 years ago, we didn't know what to do. 10 years ago, we thought we knew what to do, and it was probably wrong. And again, it's one of those things that's kind of in evolution. But I think the jury is finally in on this, and the take home is that prophylactic antibiotics in an attempt to change or to prevent the transition from non-infected necrosis to infected necrosis, prophylactic antibiotics do no good. They don't change morbidity and mortality in patients with necrotizing pancreatitis, and they do not change the transition from non-infected to infected. So I think that the jury is in that prophylactic antibiotics are not indicated. Now, certainly if the patient has another infective source that needs to be treated, well, then they need to be treated. They have a pneumonia or something else, certainly they need to be treated. But prophylactic antibiotics, just for the necrotizing pancreatitis itself, is not indicated. This is one of the papers that actually came out of the United States, which is a little unusual for pancreatitis papers. A surgeon named Pat Stellinger and another group got together, and this is a fairly decent-sized study. It's a multi-centered trial of 100 patients, and they looked at meropenem versus placebo. A lot of the old pancreatic prophylaxis literature had inappropriate agents that were used, and it was really hard to compare the data, and there's a number of Cochrane reviews that have been done, and one to be done 1 year and it'd show one thing, and one to be done another year and show another thing. But I think we're coming to consistency on this with more and more good papers that have been written, and this is one of those good prospective studies that with adequate agents that looked at a fair number of patients that really shows no difference in outcome in patients that did or did not get antibiotics. The other question that comes up, and this is something that we see at least on the surgical service, and I think that I'm sure you guys deal with, is to tap or not to tap. And this is another one of these things that has evolved, I think, over time. 5 years ago, we were sticking fine needles in everybody looking for infection, because everybody recognizes that infected or not infected is kind of the differentiator and what changes our management. They go from supportive care to interventional care, really, if we can identify an infection. And so the question comes out about how aggressive do we get about looking for that infection, specifically by doing some needle aspirate of the peripancreatic fluid. And there's not a lot of good data here, but there's some expert consensus data out there on this. And basically, this too has fallen out of favor. So routine aspiration is not indicated, and it's not indicated for a number of reasons. In a lot of respects, it's almost a self-fulfilling prophecy. The more you instrument this thing, the more likely it is to become infected. Okay, the more likely you are to go through the colon with your needle and superinfect that what is now sterile pancreatic necrosis. So again, things are changing. 10 years ago, we were poking everything, and now I think we're poking fewer and fewer of these fluid collections. There's risk of false negatives. In fact, there's risk of false positive. There's risk of superinfecting an otherwise sterile collection based on the procedural aspects, etc. So what I think we use most of the time now as our decision whether to aspirate these things or not is what do the radiographs look like? And I think in most cases, the technology and the imaging techniques have gotten so good that we can really differentiate sterile versus infected based on some radiographic criteria, and that's basically air in the peripancreatic soft tissues. Now, we'll certainly, on our service, we'll talk about some patients in just a minute with kind of lingering necrotizing pancreatitis that doesn't appear to be infected, and we'll operate on them 8 weeks later when they have non-resolution of their symptoms. And in fact, they will have some occult infection in that fluid. So this is not perfect, and there may be some patients that we're missing waiting for radiographic signs of infection that we potentially may have picked up had we done a fine needle aspirate earlier. So it's a tough decision to make. There's not a lot of good data, but the expert opinion is that you probably need to leave these things alone for as long as they can until they show clear evidence of infection, and then that's the time to intervene. And by clear evidence, I mean radiographic findings of infection, which almost always is some air in the peripancreatic soft tissues. Any question on that? No controversy, huh? I don't believe it. But there are other reasons to intervene. in sterile pancreatic necrosis. So those who we've gotten a CT, there's no air in the fluid collection or anything like that. There may be other reasons to intervene. I've talked about gastric outlet obstruction. There could be small bowel obstruction. There could be biliary obstruction based on mass effect of these either pseudocysts or peripancreatic fluid collections. Patients can have these syndromes of unwellness, and I think it's hard to describe, but I think everybody would know it if they saw it. These patients that linger in our ICUs for 8 to 12 weeks, and they're just not right. They kind of come off the vent, but they really don't come off the vent. They just, they're decrepit and wasting away, poor nutritional status. They just look unwell, but there's not, and you're fighting all these diseases of survivorship in our ICUs that they get and whatnot. They never just really get over the hump and get better. And we'll see patients, 2 or 3 of those every year, that have these apparently sterile peripancreatic fluid collections and just don't get better. They don't get worse, but they just don't get better. And those patients might be candidates for intervention. And then patients with disconnected duct syndrome, certainly that have persistent fluid collections, they generally have pain and some of these other obstructive symptoms that we see. The key for these patients, though, is you've got to wait as long as you can. Okay? They do much better the longer you wait. So these are not patients who have been in our unit for 2 weeks or 4 weeks. These are patients who've been up there at least 8 weeks, and they look unwell. Generally, it's 12. We'd like to wait as long as we can because the risk of the intervention, and in fact the benefit of the intervention, is much better the longer that we can wait. The risk of us doing harm to them with our intervention is much lower the longer we wait. Yeah?
I don't know that I've ever heard of disconnected duct syndrome. Can you tell me what that is?
I've got a couple pictures. I'll show you. It's basically a radiographic or an ERCP diagnosis where you can see you got 2 ends of the pancreas with the main pancreatic duct, and there's nothing in between. You got pancreatic parenchyma in the head, pancreatic parenchyma in the tail, and nothing in between. And it generally just leads to a chronic fluid collection, pseudocyst. Once you tap it, it becomes a fistula. But it's kind of this mung of pancreatic juice that just sits there. Okay, so infected necrosis, we've talked about how to make the diagnosis. We're going to talk a little bit about when to intervene and how to intervene, and the evolution of management of those types of things. As I mentioned before, the diagnosis of infected necrosis always warrants intervention. You got to do something. You see air in the peripancreatic soft tissues, you've got to intervene. What that intervention is, again, is evolving over time, and we're starting to evolve into what we call the step-up approach. Start small and work to big. We used to jump in with both feet, great guns, operate on these people through a big midline laparotomy, and as I'll tell you in just a minute, those patients didn't do very well. Okay, so we found that the less we can intervene, all the while controlling their source, the better they will do. Here's a paper that looked at timing, okay, and this is a study where they looked at 2 time frames, 90s to early 2000s, and then kind of the mid-2000s, and the differentiating factor was when these patients were intervened on. They were either intervened early or late in this study, and you can see that the mortality rate was markedly different in the second cohort of patients where the interventions occurred later. So it was one part of the growing body of evidence that says the longer we wait, the patients that will do better the longer we wait. So intervening early is really not good for patients. Yet another reason why imaging those folks early really doesn't help you, because it's not going to change anything. So we talked about the indications for interventions, either a suspected or a documented infection, preferably after several weeks, or in the absence of infection. We've got this chronic state of unwellness, ongoing organ failure, other symptoms, etc. So what's the intervention and what's the timing? Okay, there's a whole lot of things that we have in our armamentarium now that we didn't have 10 or 15 years ago. Certainly CT-guided drainage is important. It used to be that we thought that this peripancreatic soft tissue and edema was too either gelatinous or too semi-solid to come out those drains. And the general surgical dogma 10 or 15 years ago was that CT-guided drains didn't work very well because they didn't drain enough of the evil humors, if you will, and didn't get them out well enough, and so these patients would never do well just with a CT-guided drain. Well, nothing like fact to get in the way of a good story. The literature showed that, in fact, these patients do and can get better with CT-guided drains. Sometimes it takes a longer time, but they, in fact, do and can get better. Our GI colleagues, and again, we probably got one of the most aggressive and best interventional GI groups that I'm aware of nationwide in dealing with these kinds of things, and they've gotten really good, and they have different ways now that they can endoscopically, transluminally address some of these things. And I'll show you some cartoons and pictures of that stuff in a minute. But those patients, intervention that way also is better the longer you can wait. Okay, these collections, they need to mature and they need to organize before you have a good wall or good access to get into these cavities. Diffuse edema, there's not a whole lot anybody can do about that kind of stuff as far as debridement or drainage or intervention. It just doesn't work that well. Pancreatic or open surgical necrosectomy, and there's different types we'll talk about. Again, we'll talk a little bit more about later, but we ought to wait. We talk about walled-off necrosis, so you'll hear the gastroenterologist. They'll talk about divided duct syndrome. They'll talk about walled-off pancreatic necrosis. That just means it's mature enough to deal with. It's got to be walled off. Diffuse edema, diffuse fluid, there's not a whole lot we can do for it from an interventional standpoint. And I can tell you from experience that those diffuse fluid collections generally don't get infected. It's just edema. It's the walled off ones that don't have a good blood supply and can get super infected that often become the problem. So the current best practice for intervention is what we're going to call the step-up technique. This came from a New England Journal of Medicine article, again, out of the Dutch interventional group. But again, we start minimally invasive and then step up to some interventional necrosectomy procedure, be it endoscopic or surgical. So kind of the algorithm, you should treat these patients supportively. If they don't get better at some point in time, 2, 4, 6, 8 weeks later, you image them. You're looking for evidence of infection. Once you find evidence of infection on the CT, then you intervene. Your first intervention should probably be as minimal as possible, with generally, I think, in our institution, radiographic intervention with a CT-guided drain. If that works, great, you're done. If it doesn't work and the patient's problems persist, then you step up to the next level of intervention, which then again may be endoscopic transluminal or some of the surgical interventions that we'll talk about in just a minute. Here's that New England Journal of Medicine article that came out a few years ago talking about the step-up approach. Basically what they showed, and again, we've got to look at their groups, and I apologize if you can't read this. They're looking at a minimally invasive step-up approach versus open pancreatic surgical necrosectomy. Okay, so recognize that over the last 7 years since this study was published, nobody does open surgical necrosectomies anymore. So the comparison of these two groups has become less relevant over time. Certainly we know that a minimally invasive approach does better than the open approach, but as we as surgeons have kind of minimalized our intervention, the comparisons don't become as relevant anymore. So there's some other new studies that are going to come out looking at minimally invasive surgical techniques versus minimally invasive non-surgical techniques, which will be the real comparator that we don't know at the current time which is better. But again, these patients, the primary endpoint was death or serious complications, and those with the least intervention did much better. Here's some cartoons just for those of you in the room who may not be surgeons and really not maybe appreciate kind of the things I'm talking about. This is kind of the cross-section that looks like the CT scan that you get. The pancreas never looks that good, obviously, on the CT scan, but you'll see some areas of edema, you'll see some areas of necrosis. And what we like to do is we ask the radiologist to access that in a way that they can get a catheter into those fluid collections. So a nice point in this cartoon would be right in here to get the radiologist. You don't want to go transabdominally if you can help it. There's a whole lot of viscera and nasty stuff with poop in it that you don't want to go through to get to that fluid collection. But if you generally a retroperitoneal access to those things works good with a small catheter. We like to tell the radiologist to stay below the ribs. You can see here we're really close to the costal margin, so you don't want to take an intra-abdominal process and convert it to now a two-cavity process by going through the diaphragm. And these things are frequently infected. That can sometimes be tricky for our interventional colleagues, but we'd like to try and get them under the costal margin if we can. So this would be the first step, percutaneous drainage. One of the earlier, this is kind of a cartoon of the endoscopic first step. So you basically just do an EGD, and using interluminal ultrasound, the gastroenterologist can identify these peripancreatic fluid collections behind the stomach. They then basically take what looks like a dumbbell stent, and they'll poke a hole in the back of the stomach into the fluid collection. They'll put this dumbbell-looking stent that's got two big ends on it and then a tube in the middle. It looks like a dumbbell on its head. One of the big ends sits in the stomach, the other big end sits in the fluid collection, and then there's a tunnel or a tube connecting the two. And they use that to repeatedly access these peripancreatic fluid collections. So they can take their endoscope and some graspers and stuff, and they will pick at this dead pancreas. And they will sit down there in A6 for 6 hours, picking out little pieces of pancreas, trying to debride these things. But their results are pretty good, and it is one way that they can get. But the patients have to realize, and a lot of these are for the chronic patients, and it's really nice. They don't end up with a big scar on their belly. They have to go back to A6 6 or 8 times for 4 or 5 hours at a time, getting all this stuff picked out. But the results are pretty darn good, and it's a nice minimally invasive way to do it that's relatively aggressive and relatively new. Here's some more cartoons, kind of the progression. Here's kind of the first cartoon I told you, where the radiologist puts the catheter into the fluid collection. That's kind of the first step. Then the next step, if they don't get better, okay, they persist, or they linger, or they just don't get better, then the next step, what we've done here is a minimally invasive necrosectomy approach. We call it VARDS, Video-Assisted Retroperitoneal Dissection. So through a small incision, and we use the catheter. One of the reasons we talk to our radiologists about getting the catheter in the right place is because we want to use that as a roadmap or a guide for our surgical approach. So that's why it's real important that we talk to the radiologist ahead of time and say, okay, this is where I think I can go anatomically. Can you put the catheter in that area so I can just follow the catheter and get to it? Because there's a lot of potentially bad stuff in the way here. You got the kidney sitting right back here, and you've got the left colon sitting right here. And we basically got to get between the two safely to get to that stuff, and that can sometimes be difficult. The colon's really at risk. Sometimes the duodenum that's coming right here is at risk. Kidney not so much, but it gets in your way a lot. You don't want to booger it up if you don't have to. So you've got a lot of stuff you don't want to mess with, so it's really important that that placement is appropriate. And then through just a small incision in the flank here, we can get to these things and we can put a laparoscope in. We do it under laparoscopic guidance, so we got a light and a camera. We can look in these cavities and these little holes, and we can take graspers and pull out bigger pieces of the pancreas than the gastroenterologist can with their little endoscope. And we can sometimes get big hunks of pancreas out like this. Residents like to say it looks like a dead rat or something when you pull it out, and get a lot of that pancreatic necrosis out of there, and the patients do a lot better. So again, this is the video-assisted retroperitoneal debridement. We stick a scope in there and we can pick at it with some ring forceps and really do pretty good jobs. And I guess to really appreciate this, you have to understand what we used to do. We used to do these big laparotomies on people from here to here or from here to here. We'd leave their abdomen open. There was always a risk of bleeding and injury to the GI tract. You could never get their bellies closed, and then you had to leave them open. This is just a picture of the dead rat that you get out of there, big hunks of dead pancreas and stuff. And this open necrosectomy, although people we like to think we were doing them good, I'm not convinced we really were, because when we were doing this operation, as I mentioned earlier, we were doing it way too early. We were doing it early on people. There was still a lot of inflammation. We could actually do a lot of damage. We created a lot of colon fistulas, duodenal fistulas, biliary fistulas, all kinds of stuff. You could never get their belly closed, so you couldn't get their belly closed. Now they got fluid losses, nutritional losses, metabolic losses, risk of fistula formation, desquamation of the tissues, and all kinds of stuff. So this is in some patients it really helped, but it's a really morbid operation. They'd have prolonged ICU stays with lots of potential complications. They'd all end up with hernias, have to come back and get other operations to fix those. So the advances from a surgical standpoint that things like this minimally invasive approach have offered us, I think, is much better patient care. That we can do these through much smaller incisions with much less surgical morbidity in patients than we could even 5 or 10 years ago. You combine that then with what our GI colleagues, how they can supplement what we do, and I think we're in a much better position now than we were in the past to really help these patients with debridement. And then making sure that we keep in mind that one of the lessons learned is to not intervene too early. So I think sometimes it's probably frustrating for you guys, particularly in the MICU. You'll call us at 3 weeks and say, this guy is sick, can't you offer him anything? And we say, no, 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 we want to wait, we want to wait, we want to wait. And I'm sure it's frustrating to try and wait that out, but really the patients do better the longer that we can do that. Is there a question? This is another paper I'd just like to promote to you from the British Journal of Surgery just from a couple years ago. It's another one of those papers that gives an evidence-based algorithmic approach. So if you want something to put in your pocket, take this algorithm and put in your pocket and use it. And basically, you can see here, we're talking weeks from admission. Okay, so up here we are at 4 to 6 weeks, clinically stable. We're still doing conservative management. Okay, only if we have some positive culture or other signs, biochemical or radiographic signs of infection, then we start to intervene. And this is the step-up approach from a minimally invasive thing all the way up to a necrosectomy. And you can see here repeated necessary. These all get repeated. This is not a one intervention and done kind of thing. These patients need to be intervened on generally multiple times. And then after 6 weeks, if they're still not better, they still got a problem. These are the failure to thrives or the chronically unwells or things like that, then we intervene. But look, the time frame is after 6 weeks. So we're talking 8 weeks, 12 weeks down the line really to intervene on these people. So this is a good kind of algorithmic approach to take. This is the study that's in process right now, as I mentioned before. The initial step-up study looked at minimally invasive procedures versus open necrosectomy. Not a real good comparison. This is looking now at minimally invasive procedures that are percutaneous versus minimally invasive surgical procedures, and hopefully that'll give us a better comparison about what's better, endoscopic therapy or surgical therapy. This is still an ongoing study. There are other problems that patients with necrotizing pancreatitis can get into that will require intervention. Hemorrhage, still hear the term hemorrhagic pancreatitis. I'm not sure, when I hear that term, I'm not sure what to make of it. Hemorrhagic pancreatitis in some form or fashion is almost always the result of some visceral pseudoaneurysm rupture. Okay, so the retroperitoneum becomes inflamed. There's a whole lot of either named or unnamed vessels in the peripancreatic region. Splenic artery, various superior and inferior pancreaticoduodenals, gastroduodenal, hepatic arteries, all those are in play, branches of the splenic, things like that. All those are in play in this inflammatory milieu. And remember, you've got an inflamed pancreas that's putting out enzymes that's basically auto-digesting the retroperitoneum. And if you've got an arterial blood vessel that's sitting in the middle of that auto-digestion, it's going to erode. And what happens with hemorrhagic pancreatitis is you'll get a small erosion in that vessel. It'll bleed. There'll be a defect in the wall of the vessel. It will form what we know as a pseudoaneurysm. And under systemic pressure, over time, that pseudoaneurysm will get bigger and bigger and bigger, and eventually it'll rupture. And it'll bleed into the retroperitoneum. And it will become contained. And that is hemorrhagic pancreatitis. Okay, and that is the etiology of how it happens. So when people say hemorrhagic pancreatitis, what they're really saying is that there's some retroperitoneal peripancreatic vessel that has a pseudoaneurysm that bled. Now, a lot of these we will investigate, and the radiologist will squirt them, and they won't find anything. But some of them they will, and these are significant because to operate on these things, the people will exsanguinate. It's almost impossible to control the bleeding from these sources. So the primary management for that hemorrhage is interventional radiology and embolization. And again, you're taking these patients who've been sick in the ICU for 8 weeks. They've got contrast-induced. Now you're giving them contrast with on top of their nephropathy and everything else, and it's not a good thing to do. But they can die from exsanguinating hemorrhage if you don't take care of this. So it's one of those risks that sometimes you have to take. And so if you see a patient with so-called hemorrhagic pancreatitis, it's almost obligatory that you have to investigate those to look to make sure that that's not what we call a herald bleed. It's just a small initial bleed that will then result in subsequent exsanguination if we don't catch it early. So I would caution you on dealing with those. Then there's all kinds of fistulas that we can get as these disease process erodes into surrounding structures. Right? Obviously, the pancreatic duct is disrupted, the biliary tree can get disrupted. And again, the hollow viscus is in that area, can get eroded into with these digestive enzymes and whatnot too. I've got a case I'll show you in just a minute where you can almost watch it over time on the radiographs. The peripancreatic fluid collection just erode into the colon, and that obviously results in an infection and needs to be taken care of. And the pancreatic insufficiency syndromes that actually I guess now you're even starting to hear about on the radio. I always chuckle when I hear about PEI or something on the radio. So a couple cases I just like, and these are cases from our hospital, and you may recognize some of them initiated in your all's unit. These are all within the last, I think, 18 months or 24 months, I think, people we had here. So hypertriglyceridemia, about 5 to 10% of our patients, I think, come in with the etiology being hypertriglyceridemia, which is I think a little unusual, kind of interesting for us. We have not had to dialyze any of these people yet. They've all been treated with medical therapy and managed fairly quickly. But this can be a bad problem. She spent 4 weeks in an outside hospital. They had poked her with a needle 4 or 5 times, trying to prove that she didn't have an infection, and eventually she did. So again, it's almost a self-fulfilling prophecy. The more you poke, the more likely you are to get a problem. She was transferred here with positive cultures. She looked pretty stable. She just had a fever and a white count. All of these patients have fevers and white counts. Okay, they all look sick. They all look septic. And that's the challenging part clinically, is to differentiate who's got a real infection and who's just got an inflammatory syndrome that results in leukocytosis and fevers and everything else. So we've got to be cognizant of our spiraling empiricism and be careful to treat these patients, not treat these patients with prolonged courses of empiric antibiotics. If we don't find a source, and they've just got pancreatitis, and that's the way these patients behave. But anyways, this lady got treated with a kind of a minimally invasive step-up approach with some antibiotics and bilateral percutaneous drains, and you can see we did pretty darn well with her fluid collections. Here's the before, fluid collections on both the right and the left. You can see those, and then the resolution with drainage and antibiotics. So a good result from just a minimally invasive result. Here's another guy, 69-year-old alcoholic pancreatitis, in and out of an outside hospital. Got really frustrated with his care there and came back. You can see he's got big peripancreatic fluid collections. He underwent a VARDS because we did not think he was obstructed, but he really had gastric outlet obstruction. That was his biggest frustration. He could not eat. He vomited all the time. He was on TPN. Was really getting debilitated. You can see the anasarca. Okay, he couldn't eat. And so we did a VARDS on him through the left flank. You can see, so we do a minimally invasive approach through here to approach it rather than going midline with all the visceral organs and everything. And then we actually, I think, combined that, I think in his case, with a lap G-tube. So we got enteral access so we could give him good nutrition, because that was his big problem. He was just so malnourished, he was wasting away because he couldn't eat. So we drained his fluid collections, got him some enteral access, and he got better over a period of weeks. Another guy, gallstone pancreatitis, 4 weeks in the ICU, kind of waxed and waned, and that's how these people do. They get a little better, they get a little worse, get a little better, get a little worse. He got then acutely worse, ARDS, AKI, you can see here. His problem was a big stone here in the neck of his gallbladder. And his gallbladder, you can see it's big, it doesn't perfuse very well, it died. he had a big midline fluid collection that we weren't convinced connected with this lateral retroperitoneum. So we went midline. We bit the bullet because we thought his gallbladder may be driving some of this. Andy had this big thing. So this is a guy, one of the few open necrosectomies that we still continue to do here. But here's his post-drainage kind of thing. He got the complications that people with open pancreatic necrosectomy get. He got a post-op biliary fistula, biliopancreatic fistula. Actually, this thing completely eroded his bile duct, so the intrapancreatic common bile duct had a big gap in it. It was just part of this big inflammatory mung. So I think it was Rob Pompa, or maybe one of the other guys, I can't remember, like 4 hours in the endoscopy suite trying to get a stent across this defect in his common bile duct, and eventually did. And these guys save our behinds more often than not after we've done some of this crazy stuff to people and we can get them through this. So those guys got a stent in. You can see the stent here. His pancreatic duct, the biliary tree goes up into the biliary system, goes through the ampulla and then into his duodenum. Kept that stent for I think 6 or 8 weeks. Everything's out now. I've since fixed his midline hernia, and he's happy as a clam after being sick in the hospital for about 3 months with all kinds of complications. And these patients have drains coming out of everywhere, and they're malnourished and everything else. So, but we're getting really good outcomes with some of this stuff. This guy came from an outside hospital again after 3 weeks. He had C. diff, which is a little, but again, he got treated with a bunch of prophylactic antibiotics at the outside hospital. So he comes in with C. diff, really, really sick. Here's his initial CT. You can see the peripancreatic fluid collection. There's no air in it. I don't remember the time frames, but this is before the infection. Here's the colon, here's the spleen, here's the kidney. I told you a lot of bad stuff in the area, and here's this digestive mung sitting right in the middle of it. And then over time, you can see colon fluid collection. If you squint real hard, you can almost see a little communication there. Well, now it's a full-blown communication. Now we've got shit from the colon, excuse my French, going into this peripancreatic fluid collection. It just eroded right into it. So we had to operate on him, had to take his colon out because colon was just dissolved, basically. The whole back wall of the colon was gone. So he gets a right-sided colostomy and pancreatic debridement. I just took his colostomy down 2 weeks ago, I think. And this is a relatively young guy. He was 27 at the time. He's 28 now, I think. But finally getting better after these bad complications. We'd come by every week and you'd say do something and I'd say no, we're going to wait. You'd say do something, I'd say no, we're going to wait. Look at these fluid collections, they were huge. Just see his pelvis. This guy looked like he was pregnant. And he was skinny. You can see he's got no subcutaneous fat. But he had this chronic unwellness. He just never got better. He'd get a little bit better, he'd go to B1, he'd come back because he couldn't breathe, and all this other kind of stuff. I think he got portal vein thrombosis and DVTs, he got put on anticoagulation, all this kind of stuff. But he had this chronic unwellness. And finally, after about 12 weeks, I think we decided, okay, we're going to do him now. These things were all well matured. We actually did a weird laparoscopic percutaneous drainage of these things, just drained them, and he's done well. Now, he's got some of the residual effects of chronic pancreatitis now, but nothing terrible. I caught him. He actually got admitted because he started drinking again at some point in time and got another acute bout. But he's had nothing like this, and overall he's doing pretty well. Another one, idiopathic pancreatitis, transferred here, had failed attempts at drainage. So they put some drains in, taken the drains out. Once you put them in, you've infected that peripancreatic fluid collection. So you can't take them out. Now you got to do something. So if the drains don't work, this is before where you can see all the air in this peripancreatic fluid. And then we did a BARDS, again, which is you can almost see the incision here. Okay, a retroperitoneal approach. And again, we don't know where the colon is here. You can see the kidney, but where's the colon? Where's the duodenum? I don't know. Let's just not put a hole in it. And so we've got a bunch of drains in that area. And I think the result is pretty good. You can see the difference between the infection before and after getting that stuff drained. So through a minimally invasive approach. So I think that's really changed the way we approach these things moving forward. So in conclusion, it's supportive care. Differentiate who's infected, who's not infected. Wait. Okay, and then once you find infection, start small, work your way up, and hopefully we never get to the big, terribly morbid open operations of the past that people have all kinds of complications from. So we try and avoid this kind of massive insult. But again, we've got to get source control and measured intervention. I think that's all I've got. Yep, be happy to take questions. When I made it, my voice didn't fail.
It's really good.